Case study number 6, Kyle, by Ricardo Mathenga from the University of Texas, Rio Grande Valley. HPI. Kyle is a 12-year-old male who was arrested for breaking into the grocery store, and his mother reports being tired of a child who does not follow rules. He agreed to a psychiatric admission. PMH. As a young child, Kyle was unusually aggressive, bullying other children, taking their things, cursing, punching, and showed no concern for possible punishment, was disruptive, impulsive, and fidgety. Kyle was diagnosed with ADHD, also known as attention hyperdeficit disorder, in second grade and placed in a special education program. In fourth grade, he stated seeing a psychiatrist and was put on quetiapine and dexamethylphenidate, which he took for a while, then quit. 1 year to present admission, he had been caught stealing from school lockers, disciplined after mugging a classmate, and had several physical fights with classmates and arrested twice. Kyle was consistently unremorseful, externalizing of blame, and uninterested in the feelings of others. He was disorganized, inattentive, and uninterested in instructions. Psychosocial. Kyle lived with his mother, stepfather, and 2 younger half-siblings. His stepfather was unemployed, and his mother worked part-time as a cashier in a grocery store. His biological father was in prison for drug possession. Both biological grandparents had a history of alcohol dependence. Kyle had no known medical problems, alcohol or substance abuse, or participation in gang activities. He had not been caught with weapons, had not set fires, and had not seen as particularly cruel to other children or animals. He had been regularly truant from school, but had neither run away nor stayed away from home until late at night. Review of systems. Psychiatric. Kyle denied suicidal or homicidal ideation. He denied psychotic symptoms. He denied feeling depressed. He had no obvious cognitive deficits, but declined more further formal testing. Physical. Casually groomed and appears his state age of 12. He was fidgety and made sporadic eye contact with the interviewer. He said he was mad and insisted he would rather be in jail than on a psychiatric unit. His speech was loud but coherent, goal-directed, and of normal rate. His affect was irritable and angry. His insight was limited, and his judgment was poor by history. Diagnosis and rationale. Kyle can be diagnosed with conduct disorder, CD. This is a repetitive and persistent pattern of behavior in children and adolescents in which the rights of others or basic social rules are violated. It is more common with boys and children. Kyle does not have any remorse for his behavior even when caught. He steals at school lockers, such as a cell phone, a jacket, or a laptop computer, and at a grocery store. And when confronted by his parents, he tends to say, "And what are you going to do? Shoot me?" The child or adolescent usually exhibits these behavior patterns in a variety of settings, like at home, at school, and in social situations. Kyle, for example, steals at the grocery store and is aggressive at home, steals, bullies, and fights at school. His behavior started when young and has continued even when 12 years old, showing persistence of conduct. Diagnosis and rationale. Another symptom of CD is serious rule violations, such as being truant from school. Kyle is said to have been regularly truant from school. He generally did not do his homework, and when he did, his performance was erratic. Evidence-based practice. Conduct disorder is more common among boys than girls, with studies indicating that the rate among boys in the general population ranges from 6 to 16%, while the rate among girls ranges from 2 to 9%. Conduct disorder can have its early onset before age 10 or in adolescence. Kyle is a boy who is having difficulty following rules and requires psychiatric follow up to tone his behavior. Children who display early onset conduct disorder are at greater risk for persistence difficulties present, however, and they are also more likely to have troubled peer relationships and academic problems. From when he was young, Kyle was unusually aggressive, bullying other children and taking their things. When confronted by his mother, stepfather, or teacher, he had long tended to curse, punch, and show no concern for possible punishment. He was disruptive, impulsive, and fidgety. Diagnostic criteria for CD, according to the APA in 2013, includes aggressive conduct that causes or threatens physical harm to other people or animals, non-aggressive conduct that causes property loss or damage, deceitfulness or theft, and serious violation of rules. 3 or more characteristic behaviors must be present during the last 12 months, with at least one behavior present in the last 6 months. Kyle since early age has chronic conduct behavior where he steals, mugs, threatens, and fights classmates. He does not listen to his parents, nor is he remorseful. Conduct disorder has both genetic and environmental components. That is, the disorder is more common among the children of adults who themselves exhibited conduct problems. For example, Kyle's father was in prison for drug possession. Both biological grandparents also had a history of alcohol dependence. Parental mental disorders and child early onset disruptive behavior are well established risk factors for poor outcomes in adolescence. Social cognitive information processing, social skills, and social interactions are problem maintaining variables for aggressive behavior in children. These factors may be possible mediators for the mechanism of change in child centered treatment for CD. Treatments are available for CD. According to the Nukes and Nuckols treatment in 2016, options for CD include cognitive therapy, behavioral therapy, and a combination of cognitive behavioral therapy. Parent management training, PMT, techniques based on social and behavioral learning theory for youth with conduct disorder are also used and are far more effective in reducing behavior problems in younger children than in older adolescents. Conclusion. Kyle requires family therapy, group therapy with child or teen peers, and school support to help develop interpersonal skills and behavioral skills that foster empathy. Cognitive therapy, behavioral therapy, and combination cognitive behavioral therapy can all be included.